Welcome back to the Curbsiders. I'm Dr. Matthew Watto here with my great friend, Dr. Paul Nelson Williams. Paul, another video. We're going to be talking about insulin for diabetes, specifically type 2 diabetes, I should say, in this video.
Yeah.
Our great friend, Dr. Jeff Colburn, I guess my great friend, your mortal enemy, was back on the show,
Yeah.
Paul. And
Can't stand the guy.
boy, did he have some good stuff to teach us about. I would like to talk, Paul. Do you agree with me that it's kind of a little bit of a gray area, like when to start insulin for some patients? Like it's not always like a black and white decision. Like I think there's a little bit of room there for interpretation sometimes. I don't know if you feel the same way.
I think you should feel that way. Yeah. Like I think you should not be too algorithmic about when to start it because patients are obviously individuals, but I think there's also circumstances vary as well as to when you might start it. So like I think I don't know, like for me, I think like double digit A1C is probably a good place to start. And I think that's relatively concordant with the A1C guidelines. But I think there's some other considerations too. I don't know what other factors are you kind of looking at before you pull the trigger?
I asked you on the actual episode, and you were like, when I've tried all the other things, I usually think about it because I'm like, well, what else is there? But yeah, I think the one that both Jeff and Dr. Marie McDonald, who we recently talked to as well, they both said, like, if someone has catabolic symptoms, like if they're losing weight, they have all the polys, the polyuria, polydipsia, like polyphagia, that's a sign that they're probably insulin deficient. They're probably going to need insulin at least temporarily, and you should think about it. So if I see catabolic symptoms, that's one time where I push a lot harder to get the patient on insulin because I'm worried that they have like enough of a deficiency, and we really need to bring the glucose levels down and see where the dust settles. But that's my practice now after talking with them.
Right, because I think we've talked. I can't remember which episode we talked about this, and it may have been this one. They're glucotoxic, and you're not going to wring any more insulin out of the pancreas right now. Like you're going to need a little bit of exogenous help before it even kind of wakes up and starts doing a job if there's a job left to do. So it's once you've hit that point, they just need more help than we can give them with other non-insulin medications, I think.
Yeah. Now, speaking of insulin, Paul, I think most people are comfortable with using like glargine or your just kind of standard basal once a day insulin. Now, I thought Dedimer was more of a standard once a day basal insulin because I commonly see it prescribed once a day. And but tell me about this. What did Jeff tell us about that?
This was practice changing for me. I think anytime I've looked it up, I think Dr. Google will tell you it's a 1-to-1 conversion between levemir and glargine. It's what I've seen, at least in my geographic area of practicing. Like it just seems to be once daily medication. And it turns out like the half-life is not 24 hours. And you made the point that maybe you're trying to kind of cover the big meals if you give it just once a day, but it's really supposed to be a twice daily medication. So you would do it in even doses as opposed to NPH, which we'll talk about. But you would so if someone was getting 10 units of insulin glargine or Lantus, then you would give them 5 of levemir or Dedemir twice daily, which is different than I had been and certainly will be a change for me as I move forward.
And it makes the most difference, especially at the low doses, which you can imagine, right? Because you're giving a low dose, so it hits a lower peak and it's going to be on and off faster at a low dose. So if you look at the package insert, it says like, at really high doses, maybe it doesn't matter as much if you do it once or twice a day, but especially when you're starting insulin, you're probably going to be starting it at like 10 or 20. And in those patients, you really should be the split dosing. So that was also practice changing for me. And I'm probably going to have to be, when I have maybe a couple patients that are still on that one and not taking it twice a day, then I'm going to have to switch them up, especially if they're not doing well with their control. Right. And then you mentioned NPH, Paul. So how are you recommending people dose it after our discussion with Dr. Colburn?
Yeah, that's the stealth med, just because it's usually very affordable for patients. And so, as if you do this with any amount of time, you realize you're fighting with insurance formularies and sort of switching between different types of insulin. NPH has always been pretty cheap. But this is, as opposed to the levemir or Dedemir, where you're doing it the same dose twice daily. This one, you would do it 2/3 in the morning and 1/3 in the evening of your total dose. The idea being that 2/3 to cover breakfast and lunch, and then the 1/3 to kind of cover your evening meal. And Dr. Colburn made the point that you have to eat lunch with this. Like it's not a meal that you can skip just because you're taking this higher dose, so that you do have the risk of hypoglycemia without lunch. So you have to be a little bit consistent with meals if you're going to be giving this medication. But it's one I was always a little bit nervous around. Like, I would do it, but I would never feel great about it. But now after this episode, I feel a little bit more comfortable and confident prescribing it.
And Paul, you mentioned if you don't eat lunch, you might get hypoglycemia. So we talked about that too. Jeff recommends carrying a fanny pack, not just because they're cool, Paul, but also because they're useful if you have some diabetes supplies to carry. Tell us a little bit about, what did you learn about hypoglycemia and anything practice changing there?
Yeah, no, my favorite part of the episode was finding out that I think Jeff was being trolled by his learners who told him a fanny pack was cool. But he makes the point, and I really appreciated this, is any time that you initiate insulin, you should be doing really straightforward and clear counseling about hypoglycemia and what to look for and how dangerous it can potentially be and what your contingency plan should be. So you mentioned the fanny pack. So it's good form to have your glucometer with you at all times. And that way, when you're having symptoms, you can check your blood sugar and then counsel patients what those symptoms would be. And it's usually the adrenergic. You feel shaky and nervous and sweaty and hungry. Like if you feel those things, check your blood sugar right away.
Yep.
And then have a plan to treat your hypoglycemia if it exists. So he talked us through, I think, a couple of options, Matt. I think you latched on to one or two things.
Yeah. So I thought it was interesting. He said that even though like candy tastes sweeter, it's sucrose, which gets broken down into glucose and fructose. So it's a little slower to get the glucose in. And the glucose tablets or the glucose gel, which you can buy, that 4 tablets is about 15 grams of carbs. And he talked about the rule of 15. You want to take 15 grams of carbs, wait 15 minutes, check again. And if your sugar's not coming up, then you should take another 15 grams of carbs. And if you have to repeat that more than like 3 or 4 times, that's like an hour that you've been hypoglycemic. You should really make your way to an ER because you might need like, presumably dextrose infusion or something like that. You need
EMS should be called at that point.
Yeah. And I guess the one final point, he talked about glucagon, which is not something I've prescribed as much in, but the point he made about glucagon is it can only be given once in 24 hours because it's depleting their glycogen stores, and they would have to eat and rebuild their glycogen stores before glucagon could be effective again. And that when he gives it, if the person is, especially if they're stuporous, they should be in the recovery position because they often will vomit after they get glucagon. So it's important, if we're treating people with insulin, we need to know how to treat hypoglycemia. So get your patient a fanny pack, make sure they have some glucose tabs and gel in there or their glucagon, whatever they're going to use. But that's important. So lots on this episode. Again, we couldn't fit everything in this short video, not possible. So click on the link in the transcript to hear the full episode. And with all that, until next time, I've been Dr. Matthew Frank Watto, and we're the Curbsiders, bringing you a little knowledge food for your brain hole.
I feel like you went a little bit out of order there. It kind of threw me off. You're trying to trick me into saying it, but I'm not going to.
Okay. All right, Paul. Do you want to sign off?
Yeah, sure. And I remain Dr. Paul Nelson Williams. Thanks and goodbye.